Hold on. Now we have Professor Cedric Sheffield. Hold on, Cedric. Okay. Come here, dear Cedric. This is a person I really appreciate because we asked him to come 2018. He lost the airplane. What a mess. This doctor, I don't know. Why are he doing this to us? But then he arrived and we fall in love with him because he's such a incredible human being. And then he does heart transplant. It's like below God is a heart transplant surgeon, right? For me, it is. It's just you can move without anything, with anything, but without a heart. So for me, it's a heart breathtaking the humility this guy has, and it's funny too. So he is professor of surgery at Cleveland Clinic, Florida, chief of transplantation, cardiac surgeon. Welcome.
Well, Ingrid, thank you very much for having me. I really appreciate it. And I recognize that my profession is not often asked to sit in front of such an esteemed conference where we're talking about urologic disease and metabolism and other things. So I really appreciate the opportunity to do so. I'm going to talk today about heart transplantation and artificial hearts, a next frontier in cardiac surgery. And I have no disclosures with industry and no personal conflicts. Now, one of the questions is, well, why talk about such a thing at this conference? Well, here we're talking about men's health and some very fine detail about general urinary risk, metabolic risk, and other things. But the reality is that for men, the biggest risk factor for their entire life, the risk factor for mortality, is development of heart failure. And that applies also to postmenopausal women as well. So at the end of this presentation, we're going to be able to understand the relevant history and epidemiologic limitations of cardiac transplantation. It's great therapy, but it does have very real limitations. I appreciate the intrinsic advantages and disadvantages of biological versus engineering approaches to treating heart failure. That's wavered back and forth throughout history. With the initial thought that engineering solutions were going to be the answer. In the 1960s, early 1960s, that was the answer. But then we made tremendous biologic process, and now engineering is trying to catch up. We'll talk a bit about the market and monetary influence on the medical explorations for advancement in this field. This is very, very important. It's largely driven by private companies who have boards and need to make a profit and speak to developers. Whether that's the right approach or not, that's a subject for a conversation. It will develop with the need for regional specific innovation tailored to each country's or each region's medical system realities. I think relying upon a few countries to drive this innovation based upon monetary policy is a clinical and medical mistake. So I'm primarily going to talk about those who start out with a normal heart and develop acquired heart failure. We're going to specifically exclude considerations for congenital heart surgery in this conversation. Now, congestive heart failure is the United States' highest volume diagnostic-related group. Everybody goes in the hospital gets assigned a DRG number, and by far the largest number of patients are diagnosed with congestive heart failure. And this was a big number, more than many times more than those who develop acute coronary syndrome, stroke, infections, pneumonia, psychoses. This is a very, very large number in the U.S. and in Europe, I suspect in the rest of the world. And now, in addition to the high number of diagnosis, is associated high hospitalization costs. Heart failure is very expensive to treat, and for instance, in this a Medicare study from the early 1990s when this was really recognized. The cost to Medicare for heart failure was 3 times the cost of all cancers put together. That's not something that's well known. It's twice the cost of all myocardial infarctions. And if that's not bad enough, the prevalence of heart failure increases with age in a linear fashion, increasing first in men in a logarithmic fashion, and then postmenopausal women catch up. Now, the demographic trends are that the population in the U.S. is increasing, increasingly over age 65. It's the same thing is happening in Europe, as noted in one of the other conference speakers, and that is predicted to continue. And because heart failure increases with age of the population, the heart failure prevalence projections are going to basically double this century, very, very soon. And the cost per patient is very, very high, $110,000 to treat this one diagnosis with a large number of patients. And so the overall expenditures are really going to double in less than 20 years, and we're well on the way. Now, if we look at this slide, we're talking about these specifically this spectrum of heart failure, beginning with patients who have risk factors but no disease, patients who have structural disease, and those who have functional disease, as they progress up this heart failure ladder. But I'm going to concentrate primarily on those patients to the far right that have failed guideline-directed standard medical therapy and preventive measures. And these are the patients that I typically are referred. Now, what happens with those patients when they fail very good medical therapy? Well, end-stage heart failure that is recalcitrant to medical therapy has a very, very high mortality, higher than AIDS, leukemia, lung cancer, approaching the mortality of pancreatic cancer, which is one of our unsolved medical issues today. So a mortality rate can be 80% in 1 year for patients who failed medical therapy and developing end-stage heart failure. Well, what do we do with this? Well, the easy solution is we do heart transplant. It's an easy operation. Identify the patients. We treat them as best we can. When they fail that, then we refer them for heart transplant. We get an organ for them. We do a surgery, which in the big scheme of things is a relatively straightforward surgery. We take out the old heart. We have a donor heart that we procured and protected. We put the new heart in. A variety of different techniques, but from a surgical standpoint, one of the easiest operations that we do. And then we wind up with a new heart, new functionality, none of the disease processes that affect the heart. And what happens with those patients? Well, going from patients with typically, which has stage 4 congestive heart failure, on maximum medical therapy, now we have a patient where these patients are typically stage 1 from a congestive heart failure standpoint, and about 95% of patients have no activity limitations, or they have minor activity limitations, and that's persistent. And what happens to survival? Well, this is by era, and by era, survival has gone up, and it continues to go up, and survival is quite good. So that we expect today that conditional 50% survival is now approximately 12.9 years, and continues to go up. Now, because of these innovations, the increase in number of heart transplants has gone up tremendously. So starting in 1967 with Dr. Christian Bernard, we did the first human heart transplant, and for about 13 years after that, very, very limited utilization of heart transplants because we did not have the ability to control rejection in any way, any non-toxic way. With the introduction of cyclosporin in the early 1980s, markedly increased 1-year survival from about 63% to about 83% in the Stanford series. And heart transplantation increased and dispersed as a therapy, both in the U.S. and worldwide. Now, that increased until about 1990 and 1992 when it plateaued. And so we're 4,000, 5,000 heart transplants per year in the reporting countries. And that is a limitation due to donor availability. So if we look at the U.S., we're talking about 5 million to 8 million predicted patients, 400 to 500,000 new diagnoses a year, and heart transplantation. We were doing 2,000 per year in this country. We're now up to 3,000, 3,500, but it's just the tip of the iceberg. So while it's a very important, very effective therapy for those lucky enough to have the ability to utilize it, it is epidemiologically not important. And for some groups, such as those over age 70, we see there in blue, heart transplantation is a good short-term therapy, but in the long term, their survival is statistically less than younger age groups. So with these patients increasing in number and heart transplantation plateauing, well, what do? Well, we go from a biologic solution of heart transplant to an engineering solution of mechanical support. This is an older pneumatic left ventricular assist device we're implanting here that helps the left side of the heart. Solution for patients who are failing medical therapy but don't have access to a heart transplant either because of donor availability or special characteristics such as preformed antibodies and sensitization to the donor pool. And these early devices were rather onerous, requiring large controllers. Mobilizing those patients was difficult. Now, again, these are left ventricular assist devices. They are not total replacement for heart function. But over time, engineering progress can happen fast. And so we go from these large devices that are cumbersome to smaller devices very, very rapidly, much faster progression than biological advancement. And now we go from a large device the size of a refrigerator to a ambulatory device that's electrical and very, very small, very energy efficient. And so we get patients out of the hospital, getting back to quite a reasonable quality of life. Now, this is left ventricular assist device therapy. In the early days of implementation, this was primarily used as a bridge to transplant. Patients were getting sicker, failing medical therapy. They were at high risk of dying, and we could use the device to stabilize them, get them back home, let them improve all organ functions, decrease risk, and live a good life while they're waiting for heart transplant. So this enabled patients to wait. It did not increase availability of heart transplant. It just kicked the can down the road. And these are patients that could enjoy some normative activities. And this progression in engineering has continued for left ventricular assist devices. And this is my first group of patients when I came here to Florida, who would have all been dead except for a new program utilizing these devices. And left ventricular assist devices utilization has increased. It now exceeds heart transplantation in this country, and will continue to exceed heart transplant in terms of utilization. And these are a couple of my patients. A patient that came to us from the Caribbean, failed medical therapy, and ultimately got a heart transplant, out of heart failure back to normal activity and back to work. Another patient who came to us with a gastric carcinoma that was treated and suffered drug toxicity leading to heart failure, and came to us in cardiogenic shock 2 years after treatment for this cancer. We treated this patient with a bridge to transplant left ventricular assist device for 3 years until she was beyond 5 years, no evidence of cancer. Rigorous screening, again, had no evidence of cancer. And so we took out the LVAD, did a heart transplant, and she's back to normal activity, functional, and function. This is another patient that came to us from internationally. I don't recall where this patient came from, but was highly sensitized. Failed medical therapy, and was in cardiogenic shock. We put a ventricular assist device in. This is a small electric device. This is the HeartMate 2, and stabilized this patient with a left ventricular assist device. And the patient was able to wait for transplant. Now, again, this patient is 1,000 miles from home, but was able to wait and ultimately get a heart. All of those devices were taken out, including the defibrillator and the ventricular assist device, back to normal from a functional standpoint. This patient's more than 10 years out now. So, well, utilizing left ventricular assist device as a bridge to transplant requires an operation. They're supported with this device for a period of time until a donor becomes available. Well, what happens when due to donor limitations, there are no donor for this patient? Well, in blue there shows survival for these patients. And heart transplantation, the survival D50 is about 12.9 years. For patients with left ventricular assist device, in blue there with no concomitant procedures, the D50 is about 5.6 years. So survival is not the same. But the advantages of the device are they're made in factories, they're immediately available, and very importantly, we can schedule an operation when the patient is at their lowest risk point, which we can't do with heart transplantation. Now, left ventricular assist devices as a permanent implant, they're important, they're epidemiologically important, but they don't apply to everyone. Well, this is a quote from more than a century ago when there was a discussion in the United States about eliminating the U.S. Patent Office. And the reason to do it is because there had been so much advances in engineering and science and in industry in 1898. The thought was, well, there's no need for a patent office because everything that can possibly be invented by humans has already been invented. So we can just close the patent office off. Well, that's archaic thinking, obviously, and sometimes we can get caught up with that in medicine. Very recognizant of those advances that have been made, but understanding that the future is the future, and what's going to be invented in the future is largely unknown, and oftentimes driven by need, as opposed to biological process. And innovation, which happens very, very slowly, we can look at some of the examples of engineering progression. This device, let me ask if anyone knows what this is, first of all. Okay. Well, this is early 1900s, and this is a device designed to do an electrocardiogram of the heart. So this is an EKG machine at that time. Now, in my clinic, I carry in my pocket an EKG machine that requires 2 fingers and my iPhone to get a very good quality 6-lead EKG, as opposed to this. So again, this is engineering progress. In this device, now this picture was taken at Johns Hopkins, and I can tell because every historic picture at Johns Hopkins has a very devoted, very enthusiastic, but very stern nurse with the patient. So this fella was one of the first patients who survived heart block with a pacemaker. So this was an external pacemaker. Now I don't know, and this reminds me of where we are in terms of ventricular assist devices, because I've been here with ventricular assist devices with a patient that had a controller like this and wasn't able to get a transplant. Now what are we going to do with this patient? So evolution of blood pumps has demonstrated the difference between biologic progress and engineering progress. Let's talk a little bit about history in terms of total artificial hearts. In the 1960s, the idea adult heart surgery did not exist, essentially. Certainly not on cardiopulmonary bypass. Heart surgery was a congenital and a pediatric phenomenon. So there was no treatment for coronary vascular disease, couldn't even do a heart catheterization, no treatment for valve disease. And the idea was that at that time, when the heart was diseased enough, we'd have an engineering solution to replace the heart. And so in 1957, Koff, who was very important throughout the history of mechanical support for the heart, did his first animal implant with Dr. Coetzee, who again has been very, very important in early history. No human implants. 1967, first heart transplant by Dr. Bernard. Well, he did a number of heart transplants, but did not have the tools to control rejection. '69, Denton Cooley, with a patient under duress, did the first human total artificial heart. That patient was bridged to transplant, 64 hours of support, but falling apart throughout that support. 32 hours after transplant, the patient died of sepsis. In 1980, the advent of cyclosporin and its incorporation and marked improvement in heart transplant survival. 1981, Dr. Cooley and Dr. Kutsu used ventricular system, total artificial heart invented by Dr. Kutsu and bridged the patient after coronary bypass. The patient was about 26 years old. Bridged him to transplant. Was 55 hours of support, and after transplant, 1 week later, the patient died of sepsis. And Dr. DeVries utilized a Jarvik 7 and Bernie Clark with long support, 112 days. He died of pseudomembranous colitis. And in '85, Jack Copeland sort of entered the modern era where he did bridge to transplant support with a Jarvik 7 total artificial heart. 9 days of support, the patient was transplanted. 5 years later, the patient succumbed to lymphoma mortality. So that Jarvik 7 eventually evolved to Jarvik 70 to a Cardio West to a Syncardia total artificial heart. And from 1993 to 2001, 81 implants of this device happened under the trial with 79% survival to transplantation and 70% overall 1-year survival. Tremendous increase in survival, representing a rapid improvement in engineering evolution. And to date, there have been 1,400 Syncardia implants. It's now the only approved total artificial heart in the U.S. approved for bridge to transplant as an indication. And this device initially had a refrigerator-sized controller that came down to suitcase size, and then have the Freedom Driver, which allows the patients to go home and live a reasonable quality of life. So that's the device on the left. The device requires taking the heart out as opposed to left ventricular assist device, which is placed with the heart in place. The device has 2 polyurethane bladders. It's pneumatically driven. It has 2 tilting disc valves, and this device was invented in the early '80s. So we're talking about technology that's almost 50 years old, and this is the only device we have for total artificial heart. That's the suitcase size driver in the middle, and then on the right is the Freedom Driver, which allows mobility. Okay. So limitations and complications, its size. The device is big. It's 10 centimeters in diameter, requiring a large person to fit the device. It has 2 mechanical tilting disc valves with the risk associated with that. 2 polyurethane ventricles. We do not know the durability. It's a bridge to transplant device. It has not been used as a permanent device. It's pneumatic with an external air driver, basically 1980s technology. Complications including bleeding, hemolysis, anemia, stroke, renal failure. Renal failure may not be intrinsic to this device, but it may be a reflection of taking out the atria with the loss of atrial natriuretic factor, and we've had some handles on how to replace that hormonal deficit, and other devices, and we'll go through this very quickly. A Bivacor, which is now in an early feasibility study, and the Cleveland Clinic has a device, animal testing and human fit modeling right now. This is the Bivacor device. It's a modern technology, progression of engineering, and this device has no valves. It has a single rotor. It is a total artificial heart, requires removal of the heart, and it does biventricular support. And it's designed as to be durable as a permanent device. And there in blue is there's a single moving part, which is the rotor, and again, no moving parts. This device is small, designed for permanent implant. So as opposed to the Syncardia, which requires basically men and sometimes large men to implant it, this device can be placed in people of all size with a body surface area greater than 1.4. So women, okay, even small women can utilize. Cardiac output, from screening to support, cardiac output increased from 3.5 to 8.7, and it allows pulsatile a dynamic speed pulse. So it has a pulse, so we can measure blood pressure, we can do pulse ox, we can do these other things, so the patients can be managed clinically. And it does have a physiologic response to exercise. So conclusions. The heart transplant has the greatest longevity benefit of any therapy. The heart transplant does have limited epidemiological benefit. It's donor limited and probably always will be. We'll talk about that in another session regarding donor options. It requires long-term immunosuppression with all its morbidity and mortality risk. The total artificial heart we have today is only approved as a transplant bridge, and that device is 45 years old. It's expensive to develop these technologies. There's no long-term data on what happens with this as a replacement device instead of as a bridge to transplant. And but the newer models are developed or are designed for long-term durability. So if you look at it on the world stage, in the U.S. we have a very large, very expensive healthcare system. And as of right now, we don't have universal care. So those who have access to it can have access to very expensive technologies. This total artificial heart is very expensive on the world stage. It would benefit from local market-driven innovation. The problem with these devices being developed in Australia or the U.S. and then applied to the world stage is they tend to be very, very expensive. Companies are for profit, and when the device is developed, then they really are too expensive to have worldwide access. Now, these devices do pivot biological pathology into engineering innovation, and biological progress is typically slow. Engineering innovation can happen very, very rapidly. And I think that total artificial heart is our greatest potential future epidemiological benefit for treating end-stage heart failure. I expect there's a day when many patients will be treated by something made in the factory in unlimited quantities. I think that's it. Thank you so much.